Okay, so today's lecture is going to be about a very important topic, that is psoriasis. Psoriasis. Now, the thing about psoriasis is um, people ask, what is psoriasis, right? So, the thing about it is that psoriasis is a chronic, it's a chronic, so that's one important word. It's an inflammatory condition, and moreover, it is mediated by T cells. So, which T cells? Obviously, your T helper cells, not your cytotoxic cells, your T helper cells, and particularly the T helper cells that are involved are the TH1, the CD4 TH1, the TH17, and your TH22. So these are the cells that are involved. And which part of the skin is involved? Well, you should remember that it is going to involve the epidermis plus the dermis. And what kind of a disorder it is? It is a papulosquamous disorder. What do I mean by that? Basically, we could see certain amount of papules. So what are papules? Papules are raised lesions that are less than 1 centimeter. Now these papules could later become a plaque when it's more than 1 centimeter. So this is a papule, and this is a plaque, essentially. Now, what could be the causes of it? What could be the cause of it? Well, the cause could be simple. You could have, first of all, a genetic predisposition to this psoriasis. So you have a gene which is named after the disease itself, which is called as a SORS1 gene. And if you have the SORS1 gene probably on your chromosome 6, then obviously you're at a very high risk of getting psoriasis, 50% chance of getting psoriasis. The second cause is going to be an infection by group A streptococcus, beta hemolytic streptococcus, which basically is strep pyogenes or any of those types. So group A, streptococci, obviously group A, which means beta hemolytic, all right. And that was going to cause a disease called as guttate psoriasis. Now, what is guttate psoriasis? Because we've spoken about guttate psoriasis, it is a type of psoriasis. Now, psoriasis could be of different types, right? So guttate psoriasis is a psoriasis that is seen obviously in children. And what else could the children have? The children with tonsillitis, obviously. That's obvious, correct. And what do you see on their body? Well, on the trunk, you're going to see guttate. Guttate basically means raindrops, so raindrop like lesions. So you're going to see raindrop like lesions on the trunk. And more importantly, you want to treat this. And how do you want to treat it? You're going to treat it by using a macrolide, right? Because you want to eliminate, first of all, treatment is to eliminate streptococci. So because of that, you're going to use something as an erythromycin. Would you go for any other antibiotic? Probably you could go for any other antibiotic, but obviously you need to be careful of the drugs which could be. So there is also a list of drugs that cause this particular disorder, which you should keep in mind, which I use as LAMB. So L is for lithium, which is an antipsychotic. A for anti-malarials. So it could be chloroquine, primaquine, atorvastatin, blah 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 blah. Sorry, not that. My bad. Not atorvastatin, but obviously chloroquine, primaquine, stuff like that. And beta blocker, and very important ones are NSAIDs. Some of the NSAIDs too could cause psoriasis, very important. And systemic steroid. So I'll write it differently, systemic steroid, because there is a condition which is caused due to systemic steroid, and that is pustular psoriasis. So there are some people who take systemic steroids, and when you rapidly stop these steroids, All right, when you stop these steroids, you could have pustular psoriasis. And what that basically means is that instead of having papules, usually psoriasis is a disorder where you see papules, right? So you see papules, but now these papules have now become pustules. And why they become pustules? Pustule basically means there is pus. Now this pus that is there, it is sterile pustules. And these so basically, if it was, let's say, bacteria or any other cause, any other microbe, then we would call it a vesicle or a bullae. But definitely it's a pustule, which means it is sterile. And pustules are seen on the trunk, pustules on trunk. And these pustules, they later coalesce, they basically coalesce to form something called as lakes slash sheets of pus. And this is very similar to those lakes of algae that is seen on the body. So you could see something like that. You could see pus and lakes. Now the thing about it is that a very important MCQ could be formed because of pustular psoriasis. In pustular psoriasis, you could have a generalized involvement of the body, right? And you could also have a localized involvement of the body. So when it's a generalized involvement of the body, it could have an acute form, and it could have a form that is present in pregnancy. Now acute form is basically that you've stopped steroid and there is an acute reaction, which is called as the von Zumbisk type. Another just a fancy name. But what's important is that what happens in pregnancy. Well, in pregnancy, if this systemic steroid, or let's say just because of the pregnancy factor, all right, let's say because of pregnancy, there's something called as a pustular psoriasis of pregnancy, which is also very ironically called impetigo. All right, and impetigo herpetiformis. So a very important answer could be an MCQ. That could be, what is impetigo herpetiformis? And it's nothing to do with the disease caused by streptococcus, which causes impetigo, nor is it something to do with herpes. Rather, it is something to do with pregnancy or due to stoppage of steroids. So something which is associated with pregnancy and stoppage of steroids, and is pustular psoriasis. Obviously, when it comes to streptococcus pyogenes, impetigo is seen, but that is just impetigo and not this particular disorder. And if it is streptococcus pyogenes or streptococcus A, group A associated psoriasis, then it has to be guttate psoriasis. Another very important cause of psoriasis is the season. Well, it's season. So if someone tells you that they have intense itching or they have intense scaling in a particular season, as winter, you could probably think that it could be psoriasis. And that is about it, about the causes. And we just spoke about the causes and some particular causes with some particular variants of psoriasis. Now, a very important thing about psoriasis is that what do you see? Like, let's say if someone comes to you with psoriasis, he's a guy who comes to you with psoriasis, what are you going to see? First of all, you're going to see a lot of scaling. So the skin is showing scaling. And why? Because there's something called as an hyperkeratosis. Now, there's something called as an hyperkeratosis of the patient, and also you're going to see a lot of pustules, which pustules could later become plaque, right? And you could see a lot of pustules. That's just generalized idea about psoriasis. And why all of this occurs? Because obviously your T cell reaction, and they secrete a lot of interleukins. They secrete interleukin 17, interleukin 22, interleukin let's say they also secrete interleukin 2 probably, interleukin 12, then interferon gamma, tumor necrosis factor alpha, all of these, interleukin 2, interleukin um, 22. Yep, all got all of them out there. So that's the reaction. It's just a reaction that has occurred to all these interleukins particularly. Now the types of psoriasis is something that we need to wonder. What are the types of psoriasis? Now, the first type of psoriasis is going to be a chronic plaque psoriasis, which is the most common form. So I'm going to write that at the very end because it's the most common form. One is that we've seen is that guttate psoriasis, and I've spoken about it. I've spoken about the treatment and also about the cause. Second is the pustular psoriasis. Its acute form, its pregnancy form, acute form is called von Zumbusch type or von Zumbusch disease, and the pregnancy is called as impetigo herpetiformis. That's the second type. Now let me talk about the third one. We've spoken about these two in the cause itself. Now let me talk about the third one, which is called as erythrodermic psoriasis. I'm going to write psoriasis by P. All right. So erythrodermic. Erythro means red. Dermic means skin. So red skin. Isn't that obvious? So this is psoriasis that makes the body have a greater than 90% body is red. All right. So greater than 90% of the body is red. That is obviously because it's erythroderma, that means it's erythema is seen, and obviously because it's psoriasis, scaling is also seen. All right, you could also see a little bit of pustules here and there. And what is its other name? It's also called as exfoliative dermatitis. Now, exfoliative cause because of scales and dermatitis cause psoriasis is an inflammation. How do you know that exfoliative dermatitis is nothing but psoriasis? Simply because of the fact that this is something that you need to remember, but it gives you a clue that it's something to do with inflammation and something which is scaly. Because of that, there is exfoliation. Now another type, this was the third type. We have the fourth type, which is called as nail psoriasis, and this is really interesting because of the fact that nail is a very important indicator. Nail is a very important indicator when it comes to nail psoriasis, and it's and actually nails and the digits themselves. When you look at the nails, have a characteristic finding. So the nail changes that I could tell you first is going to be pitting. What do you mean by pitting? Let's say this is the nail bed, all right, and this is the nail plate, and this is the nail bed. All right, so the nail that we commonly call the nail, the keratin part, is actually the plate, and the below thing is the bed, which is more vascular and has a lot of tissue, whereas this is just dead. And what's important is that in the nail plate you would have a lot of pits, and the pits would be more in the proximal part, in the proximal nail matrix. So this is called as a pitting. Pitting is seen in nail psoriasis or even in chronic psoriasis as a diagnostic marker. Something as called as subungual hyperkeratosis. What does that mean? So basically this is your nail, all right, and this is your nail plate, and sub means below, ungual is nail, and hyperkeratosis means increased proliferation of the keratin. Correct? So if this is your nail bed, right, this is your nail bed, this is your nail plate, and out here I'm going to use red because that's the more alive part. There's going to be a lot of proliferation, so a lot of cells are going to go upwards, and when they go upwards, what they do is that they basically push the nail bed upwards, like instead of the nail beds and the nail plate being together, the nail plate is now pushed upwards, and this entire process is called onycholysis. Oni means again nail, and cholysis means septation, or lysis, complete breakdown. So that's subungual hyperkeratosis that can lead to onycholysis. Coming to the fourth very important feature of nail psoriasis, or in general psoriasis, that could be one of the markers, is something called as an oil drop sign. Wow. So far what we've seen is let me just recap all let me just explain oil drop sign, and then I'll recap what all the other signs were. So oil drop sign is a reddish red salmon like spot in the nail bed that sees that sorry that can be seen rather that can be seen from the nail plate. Well, that is about it. And what other important thing that I think, so let me just tell you about the all different very important characteristics that are there. First, you will have subungual hyperkeratosis. Second, nail pitting. Then third, you would have onycholysis. And fourth is oil drop sign, isn't it? Or the salmon patch, that is more commonly called. Now, once these four signs are taken care of, we've taken care of nail psoriasis, more or less. Now, coming to the very important psoriasis, that is which nail psoriasis was the fourth one. So the fifth one now is going to be joint psoriasis. That is psoriasis that involves the joints. Now, joint psoriasis is basically a very crude way of saying it. What it actually is rather arthropathy, or let me write it better. Psoriatic arthropathy. This is the right way of writing it. But what that basically means is that there is joint involvement. But a very important thing to remember is that it is seronegative, that is Rh factor negative, and it is erosive. So that's something scary when it comes to as a symptom. So basically, your digits, so your distal interphalangeal joint is most commonly affected joint is your distal interphalangeal joint. So let's say this is your pharynx, this is your middle phalanx, and this is your distal. So this joint is good, but this joint isn't. So what happens is that there is something called as a scooping of the middle phalanx into the distal one. All right, so it's called the pencil cup. So the middle phalanx actually tapers into the so this is your normal, and what happens now because of psoriatic arthropathy is that you would have this, basically it's cupped into. All right, so it's erosed from here and it's cupped into. Now, because of that, your digit is shortened because of erosion, and also that your entire digit is showing psoriasis itself. So the skin over the digit is inflamed skin. So what it actually appears as a sausage. So we call it as sausage digit, very commonly called. All right, now after covering that particular psoriatic arthropathy, let's come up to the most common one, that is the chronic plaque psoriasis. Now the idea about this is that why we are studying chronic plaque psoriasis, because a lot of the disease itself is a chronic plaque psoriasis, and we can study all the different histopathology, clinical features, symptoms, everything with this particular chronic plaque psoriasis. So very important is uh, chronic plaque psoriasis. So the first lesion that you're going to see is in on the skin. So what is very observable, and first of all let me tell you the symptoms. The symptoms are going to be scaly, itchy, pruritic skin. Simple. But what about the skin? What about the clinical features or the morphology? Well, on the skin, you're going to have large scaly red papules, scales, and so basically scales plus papules or plaques. But where? The site is more important, because that's what separates the psoriasis from lichen planus. It's on the extensors. That is, it could be on the elbow or it could be on the knee. Correct. Now, what all signs do we have actually? What all signs do we have? There are 3 signs that you should know of that are very important to psoriasis. First is auspids, second is Cobner's, third is Warnoff. Now, auspids is that when basically there is, let's say, a lesion or a scale. I take a glass slide, all right, I take a glass slide, and when I rub this lesion with this glass slide, I'll see some amount of bleeding. And I see that bleeding because of the fact that in psoriasis, at the level of the dermal papillae, I would explain this later as well, but at the level of dermal papillae, let's say these are your retinal ridges and this is your dermal papillae. At the level of dermal papillae, there's a lot of vascularity. So every time I take a glass slide, and basically when I'm rubbing the entire lesion, what I'm doing is that I'm even taking out this part, and which is causing bleeding, which is not normally seen because the blood vessels are not all the way up to dermal papillae. Now, Cobner's phenomenon is basically straight lines, lesions that are seen after, let's say, a scar. So there's a scar, you would see a certain amount of lesions. And Warnoff's phenomena, Warnoff's ring, is, let's say if this is your psoriatic papule, all right, you're going to have an area of, or you're going to have an area of depigmentation or hypopigmentation. You wouldn't have an area of depigmentation, but obviously you would have an area of hypopigmentation. Why does that occur? It because of I mean, I would just like to remember it. I don't know if there's a particular reason. They say that it is due to prostaglandin inhibition synthesis, but I don't know about how true that study is. All right, so you should know 3. One is auspids, one is Cobner's, and one is Warnoff's ring. Sorry, Warnoff. My bad. Warnoff, Cobner's phenomena, auspids phenomena, or auspids bleeding, Cobner's lines if I want it, and Warnoff ring if you want to say that, to help you remember what it could be actually. Now, very importantly, let me tell you about the histology. Sorry. Histology. H&E. So what are we gonna see? Well, let's say if I want to illustrate it in one diagram, this is your stratum corneum, this is your stratum granulosum, this is your stratum spinosum, and this is going to be your stratum basale, and a little lower, this is going to be your epiderm or dermal junction, and then this is going to be your dermis. Now, your stratum corneum is going to be thickened. Look at that, look at that, look at that. And very importantly, it's going to be thickened, and you're going to see a lot of nuclei. So I'm going to write hyperkeratosis, and there's something called as a parakeratosis. What that means is that there's going to be presence of nucleus. I'm going to circle it like this to remember that there's going to be presence of nucleus, and there's going to be also hyperkeratosis. So this is hyperkeratosis, and there's also going to be presence of nuclei. Now, what about stratum granulosum? Well, stratum granulosum ideally should have been this much, but now we're going to reduce it because stratum granulosum is reduced. There's an absence of stratum granulosum. What about stratum spinosum? Well, stratum spinosum shows a lot of acanthosis. That basically means that the stratum spinosum has been thickened. So acanthosis, thickening of the stratum spinosum. And more importantly, we're going to see a lot of microabscisses formed in stratum spinosum. So we're going to see a microabscess, another microabscess, and another microabscess, and another microabscess, which is going to be called as COG. Microabscess, which is having neutrophil. So I'm going to write an N, but do not confuse. Let me just write an N inside or on top. So it's going to be a neutrophilic microabscesses formed in stratum spinosum, which we are call as COGOG. All right. Now, where else are we going to see a microabscess? Let me change the color. Out here, I'm going to see a neutrophilic microabscess of Munro. And a neutrophilic microabscess of Munro, a neutrophilic microabscess of Kerg. Let me just make this red too. And that being about it when it comes to spinosum. And finally, your basal is almost the same. I mean, there's not much that is happening in the basale, stratum basale. But what's actually happening is at the level of epidermodermal junction, there is elongation of the rete ridges. So look at this rete ridges, they are elongated, right? They are elongated. And obviously, as I told you about the Auspitz sign, the dermal papillae have a lot of blood vessels. Oh my goodness, look at that. So every time you rub the lesion, you're gonna have bleeding. All right, so that's basically the H&E of the skin in the case of psoriasis. How do I want to treat it? I'm going to go really quick about it. Well, you want to do a topical. You want to do topical, and first of all, you want to reduce the scaling. So you want to give a moisturizer called as emollients. You want to give anti-inflammatory like a topical steroid. Obviously, you never give a systemic steroid for obvious reasons, as I've already spoken. You could also give an anti DNA synthesis inhibitor like a coal tar, or just a second, really bad handwriting that again. You could give a coal tar to inhibit DNA. All right, or very important is that you could normalize the keratinization, or you could decrease the hyperkeratosis by giving a vitamin A analog, and that is basically tozarotene. Actually, what I mean is you have to give a retinoid compound. So if you give a tozarotene, you're going to normalize the keratinization. And you could also give a phototherapy by using UVB lights having a 311 plus or minus 2 nanometer radiation UVB wavelength. All right, and before giving the UVB or there's another method called as PUVA, where you give psoralen. Psoralen is a photosensitizer. So basically, when every time you apply psoralen, your UVB penetration is going to be increased. So that's why you give psoralen. If that does not work, let's say you want to go for systemic therapy, obviously again you want to go for a vitamin A analog, which is called acitretin, and this is something that we give very regularly, acitretin. And more expensive, or actually the more common one, is cyclosporine. Cyclosporine is another drug that is actually a calcineurin inhibitor. So what it does is that it is going to inhibit your calcineurin, and this is going to decrease the interleukin 2, and by decreasing interleukin 2, you're basically decreasing your entire psoriasis. And cyclosporine is actually cheap, so you want to go for it. Also, what you could do is methotrexate. Why? Because it's going to decrease your DNA synthesis, and because it decreases DNA synthesis, you would have less hyperkeratosis, less multiplication in the stratum basale is decreased. Well, basically this multiplication was increased, now it's decreased, and because of that reason you would have less multiplication in the stratum basale. So you could use methotrexate, cyclosporin. First, obviously, you want to go for acitretin. And last thing that you could probably do is go for a systemic steroid. Let's say if all therapies fail. And you could also go for something called as an apremilast. You could go for an apremilast, which is not the same as acitretin. But apremilast is PDE4 inhibitor, and PDE4 inhibitor is basically going to increase CAMP. Now, when your CAMP is increased, note, when your CAMP is increased, CAMP is a very good molecule because of the fact that it decreases inflammation. So you want to increase your CAMP, and anything that increases CAMP is going to decrease inflammation. So in a way, this is a good molecule that could help. So apremilast, we've got methotrexate, we've got cyclosporin, and obviously your acitretin. Acitretin is a vitamin A analog, and that, as I told you, vitamin A is going to regulate the entire keratinization process. But the side effects of vitamin A is that, first of all, it's a lipid. So because it's a lipid, your increased TAG, increased cholesterol, and vitamin A is also teratogenic. Sorry, my bad. And that is about it. Obviously, your last is going to be your systemic steroid, and that's only when you have a patient of having pustular psoriasis, which is due to withdrawal of steroids. It's not a treatment as such, but it's done to prevent pustular psoriasis. That about being it. That's done with psoriasis.